Welcome everyone. So my name is Kevin Schleich, and I recorded one of these a couple years ago. So either we're short on speakers or this went over okay. So I'm back to talk about optimal medication management and movement disorders. My job at the University of Iowa is predominantly in the family medicine clinic, but I do spend a couple half days per week in our geriatric assessment clinic. So this is something that I deal with some frequency, and have had the opportunity to see a lot of patients with a number of these disorders. So I will start out by saying I do not have any disclosures. That last bullet point I should mention that I do talk about one medication that we use off-label, and that'll specifically be in the essential tremor topic, but I'll be very clear when I talk about which medication that is. But otherwise, no disclosures to tell you of. So we'll basically, as the title suggests, we'll be talking about movement disorders today. And I think any presentation should really start off with some epidemiological data, just so we know to what magnitude we're talking about some of these things. So I'll spend just a little bit of time talking about what the prevalence of some of these are. And then as a pharmacist, it's always my job in our clinic to, when we have a patient who comes in with a new complaint, to see if we can blame that complaint on either a new medication or an existing medication that a patient's taking. And so I do want you to become a little bit more familiar with some medications that commonly can cause side effects that actually mimic some of these movement disorders that we'll be talking about. And then kind of the meat of the discussion is going to focus on basically four main movement disorders. The next slide will show you that there's a lot more movement disorders than the four that we're going to talk about. But I chose these four for a couple different reasons. Number one, they're probably the most common that you're going to see. Number two, they actually have some medications that we can use that can be effective. And so we'll talk about each of these movement disorders separately. And then I'll talk about medications in terms of what the optimal doses are and the optimal durations of treatment. And then some common and concerning side effects with each of those as well. So as I mentioned, there are a number of movement disorders that we're probably all familiar with. And like I mentioned on the last slide, we'll really just focus on the four that are highlighted in green. So dystonia, essential tremor, Parkinson's disease, and restless leg syndrome. So as I mentioned, I think the epidemiologic data is important. In fact, the prevalence of all true motor disorders is actually very small compared to some of our other disease states. So only less than 1% of patients are affected by true motor disorders. And Parkinson's disease, which is actually one of the most prevalent movement disorders, occurs still relatively rarely. And that's only 1 in 160 cases per 100,000 people, which is well less than 1% of the population. Because of the low prevalence, unlike a lot of our disease states that we talk about, so things like cardiovascular disease, things of that nature, we really don't have a large body of evidence that supports the treatment recommendations that we have for really any of these movement disorders. So we're going to start with the patient case here. I was told that patient cases and kind of clinical experiences are well received. So we're going to start with JB, who's a 72-year-old female who has bipolar disorder and has been successfully treated with lithium 3 times a day for, per her report, at least 50 years. She recently has become extremely anxious due to kind of situational circumstances. She was moved to an assisted living facility and was started and titrated up on sertraline and is now currently at 100 milligrams daily. And this titration has taken place over the past 2 months. Unfortunately, she's developed some dystonic movements over the past 3 weeks. And as I mentioned, she's currently taking both lithium and sertraline. And then her other medications also include aspirin, calcium, and then a multivitamin. Of note, her chem panel looks normal, and her lithium level, which was just checked on this day, was therapeutic at 0.8 milliequivalents per liter. So with this patient, what is the most likely cause of her dystonic reactions? And I want you to think, is it either an acute onset dystonic reaction that we would kind of consider an idiopathic cause, or would you be more likely to point your finger at a drug-induced issue? So I would be more willing to point my finger at this being a drug-induced dystonia. Again, like I mentioned in clinic, it's always my job to kind of see if a new symptom or new constellation of symptoms can ever be pointed to as a new drug reaction for a patient, even if it's something that patients have been on for a long period of time, but absolutely if someone has been started on a new medication. So with that in mind that we think it is an acute drug-induced dystonia, which medication could have caused the dystonia in this patient? Would we think about the lithium, the sertraline, or the calcium? So this is a bit of a trick question because actually 2 of these could. The lithium and the sertraline are both well known to have a potential to cause some dystonia. So the last question is, what do you think is the medication that is most likely to have caused the dystonia in this patient? Same three sets of medications, so the lithium or the sertraline, we can probably feel pretty good that it's not the calcium since it wasn't the right answer for the last question. So this may actually come to a surprise to some people who may not be as familiar with the fact that SSRIs are a pretty common offender for causing dystonic reactions. But I would actually be more likely to point my finger at the sertraline strictly based on the timing of when she started the medication. Per her report, she's been on lithium for up to 50 years and has never had a problem with it, specifically with the fact that her lithium levels are within the therapeutic range. I would be much more likely to think that this is caused by a medication that was just started within the past couple weeks. So dystonia is a movement disorder characterized by prolonged tonic contractions of either a muscle or a particular set of muscle groups. Dystonia can be broken down into both focal dystonias, which are things that just affect one part of the body, and I've included some pictures here of specifically cervical dystonias and dystonias of the hand, or we can see general dystonias, which affect all parts of the body. So as I mentioned, I think it is important that we at least familiarize ourselves with some of the medications that can mimic the movement disorders that I'll be talking about today. And more than any of the other movement disorders, there's a number of medications that can cause dystonia. And the vast majority of these medications are medications that we use to treat mood disorders. And I think anyone who has any familiarity with these drugs probably recognizes the vast majority of these on this list, particularly the first generation antipsychotics. Anyone who's worked with those knows that haloperidol and fluphenazine are very well known to cause dystonic type reactions. And although the atypical or the newer antipsychotics technically have a lower risk of causing these reactions, they certainly are not devoid of that risk either. It is important to mention that SSRIs also have a very real possibility of causing dystonias, and I think this escapes some people at times. And then other miscellaneous antidepressants like bupropion and mirtazapine also can cause these reactions. Now I should mention that this list is not all-inclusive. These are just examples for each class of medication. So just because a certain SSRI is not listed in that category does not mean that it's not been implicated in dystonias. And just another reason to dislike benzodiazepines, and as you'll see in a couple slides here, although benzodiazepines can actually be used as a treatment for dystonias, they also can cause them as well. Now, it's not just medications that we use for mood disorders that can cause dystonic type reactions either. Again, some of these probably are familiar to you. So basically all the anti-Parkinsonism medications across the board, anti-nausea or GI medications, metoclopramide should really be one that sticks out to you and is a big offender for this. Both abortive and preventive migraine treatments can cause dystonic type reactions. And then I just thought some of these other medications are things that we see quite frequently, and actually a couple of these were new to me. Things like allopurinol and pregabalin, and then certainly some over-the-counter things like diphenhydramine and pseudoephedrine can also cause these. So I think these two slides really highlight the importance of, if a patient does come in with a new onset dystonia, that there's a number of medications that we need to be thinking about, and we really have to make sure that we take a very good medication history for them. So for the treatment of dystonia, as I mentioned, if we can identify a medication that could potentially be a causative factor, we should consider tapering and discontinuing that agent and seeing if the symptoms do improve. Unfortunately, as you can imagine, some of these medications, particularly the antipsychotics, it may not be safe to do the taper or the discontinuation of the agent, so you may still need to initiate treatment of some sort. And if you do need to initiate treatment, there's basically three main modalities that you can think about. The scope of this presentation is really going to focus on oral medications because personally I'm not very familiar with Botox injections and certainly not familiar with the deep brain stimulation. But those are two options as well. However, the oral medications is what we'll spend the most time on. Now this table can look a little daunting at the very beginning, but I do want you to look at just a couple things. So the first thing I want you to look at is the class of medications and the specific examples. And if you look at these, I hope as someone who's dealt with geriatric patients in the past, these medications should make you cringe. These are all definitely medications that we probably are not too excited about starting in our geriatric population. And the reason for that is if we look at the adverse effect column. Most of these things are things that can be very, very detrimental to these patients. So dizziness, falls, urinary retention, things of that nature are all things that can be very dangerous. The other thing that I want to mention is not only are these potentially unsafe and cringeworthy to look at, but the efficacy column is actually very unimpressive. So the anticholinergics, I guess, can flaunt the fact that they have the greatest efficacy for treating dystonia, and that still the expected efficacy rate is only about 40%. And that class of medications in general should absolutely be avoided in the geriatric patients because of the side effect profile. Now, one medication, I guess a couple medications that we could think about. So the dopamine agonists, or dopamine in itself, is something that can potentially help with dystonia, specifically if it's a dopa-responsive dystonia, and that's a very small subset of dystonic reactions. But that's something that we could consider using, and I'll talk much more about levodopa and the dopamine agonist when we talk about Parkinson's disease. But also gabapentin, if you notice at the very bottom there, is something that while the efficacy is not great, if we start at a low enough dose, like 100 milligrams, maybe at bedtime, and see if the patient tolerates it, that might be something that could provide some benefit for patients who have dystonic reactions. So for each of these movement disorders, we'll basically go through it like I just did with the dystonia. So we'll talk about some epidemiologic data, we'll talk about medications that we use to treat them, and then we'll finish up with a review. So with the review of the dystonia, as I mentioned, I think it's important to always look for a reversible cause. If we can point a finger at a medication and we can safely taper or discontinue the medication, that should be one of the first things that we consider. However, if we do need to use medications, we really need to be cognizant of the adverse effect profile that comes with these, and a number of them probably are not good options for our geriatric patients. Moving on to our second movement disorder, we'll be focusing on essential tremor. Now, essential tremor is characterized by a high-frequency tremor that most often affects the upper extremities. However, it can also involve things like the head, the voice, the tongue, and even the lower extremities. And while oftentimes not severe, essential tremors can certainly interfere with activities of daily living, such as eating, drinking, and even getting dressed. Now, the essential tremor is very different from a Parkinson's tremor. So essential tremor is typically bilateral or symmetric. It happens to both hands, both limbs. And a couple things that are of note, and obviously you're not going to give patients alcohol in clinic to see if the tremor improves, but generally an essential tremor will improve with alcohol, and it'll actually worsen during times of stress. So if the patient is emotionally or physically stressed, the essential tremor can actually get worse. Now, as I mentioned, oftentimes an essential tremor is mild and actually requires no treatment. But when those activities of daily living are impacted, you can consider one of two treatment options. So we can consider using beta blockers or primidone. Also, Botox, again, has been shown to be helpful for a very specific essential tremor, so the one that affects the vocal cords. And again, deep brain stimulation therapy has been shown to be somewhat effective in extremely severe and drug-resistant cases of essential tremor. But those certainly are outside the scope of this talk, and I'll focus on really just the beta blockers and the primidone. Now, this slide is just really a quick review, so we're all on the same page in terms of talking about beta blockers. So if we remember, there are both beta 1 and beta 2 receptors. The beta 1 receptors are isolated to the cardiac muscles, where the beta 2 receptors are kind of located all out throughout the body, including the lungs, the vascular, and the uterine muscles as well. And how these receptors react to activation is very different. So the beta 1 receptors, activation of those actually leads to increased contractility, which is why utilizing beta blockers, things like metoprolol, carvedilol, atenolol, slow down the heart rate. Beta 2 receptors, on the other hand, when those are activated, it actually leads to relaxation of the muscles. And this is obviously beneficial in the lungs and potentially in some of the vascular and the uterine muscles as well. However, when these get blocked, there can be some benefits and some disadvantages as well. So specifically thinking about the blocking of the beta 2 receptors in the lungs is something we certainly want to avoid. So again, just as a reminder, the beta 1 selective blockers are listed there. We will focus specifically on the non-selective beta blockers for the treatment of essential tremor, and then there's also combined alpha and beta blockers as well. Now, in that class of the non-specific beta blockers, propranolol is really the one that we talk about most frequently in terms of treating essential tremors. Unfortunately, and this actually is a pretty common theme for this, the exact mechanism for the effectiveness in essential tremor has not really been established. It's thought that there might be a couple mechanisms at play here. First of all, blocking of the peripheral non-cardiac beta 2 receptors, so the ones that are not in the heart, that are specifically located in the muscles, actually may decrease the activation of that and decrease the essential tremor. Additionally, propranolol is highly lipophilic, which means it can easily cross the blood-brain barrier. And so there's thoughts that that has a beneficial effect for essential tremor as well. Now, when we use propranolol for treating essential tremor, especially in the geriatric population, we certainly want to take the motto of starting low and going slow in terms of increasing the dose. Now, you may be thinking that extended release provides a much easier pill burden for patients, and it's easier for patients to remember. But unfortunately, extended release propranolol only comes in a 60 milligram tablet. That's the smallest tablet. I guess it comes in bigger tablets as well. But that's the smallest tablet you can get. And that's probably a higher dose than you want to start, specifically in a geriatric patient. So I probably recommend that we start propranolol with the immediate release dose and at 10 milligrams twice a day, just to make sure that the patient tolerates it. And then we can titrate that dose based on whether or not it's working and whether or not it's being tolerated. If you do get to a dose that is up to 60 milligrams per day, you certainly can use the extended release version if you want to simplify the medication regimen, but I definitely wouldn't start at that level to begin with. Propranolol is also potentially used as an as-needed for the tremor if it's associated with something that's related to stress or anxiety. So if a patient's going out in public situations or they're going out for a public dinner and that seems to exacerbate the essential tremor, you can certainly have the patient try taking just a dose of the propranolol prior to participating in those activities as well. Now, like any class of medications, there are concerns. And specifically with propranolol, up to 66% of patients experience adverse effects with this. And this is important because this is up to 66% of all patients throughout the age spectrum. And you can actually pretty much guarantee that this is going to be a much higher number when you're talking about geriatric patients. Some of the common side effects are obviously fatigue, dizziness, hypotension, bradycardia, sedation, exercise intolerance. It can also lead to erectile dysfunction. Some of these are much more concerning than others, particularly in the geriatric patients. And then there's also some serious adverse effects, so things like heart block and bronchospasms, again, like I mentioned, because they're not specific for just the muscular receptors. Now, there are both absolute and more precautionary things that we need to think about with beta blockers. So obviously, if a patient has severe bradycardia, if their heart rate's less than 50 at baseline, you're not going to want to give them any kind of beta blocker, including propranolol. Obviously, if they have decompensated heart failure or unstable angina, you'd want to make sure that those are in a more stable state before you start propranolol. It previously was thought that asthma and COPD were absolute contraindications for utilizing beta blockers. That's not necessarily the case. However, we generally feel a lot better about using the beta-1 selective beta blockers in patients with asthma and COPD. So you may still not be that excited to use propranolol in a patient who has either severe or uncontrolled pulmonary disease. Also, beta blockers obviously blunt one of the protective mechanisms of patients becoming hypoglycemic, so it blocks that ability to become tachycardic if your blood sugar is way too low. So those are just a couple things that we should be careful about with propranolol and all beta blockers for that matter. So the second medication I'm going to talk about is primidone, and as I mentioned in my disclosure slide, primidone is used as an off-label medication for essential tremor, so it's not FDA approved for the treatment of essential tremor. And much like propranolol, the precise mechanism of action for ET is not fully understood. Now, you may know that primidone is a precursor to a couple active metabolites, one of those being phenobarbital. And the anticonvulsant activity of primidone is thought to be both due to primidone and the active metabolites, again, specifically phenobarbital. And primidone is much more effective for the treatment of essential tremor than phenobarb. So with that being said, we can oftentimes get away with much, much lower doses of primidone as an essential tremor treatment than what we can as an antiepileptic. When we're using primidone as an antiepileptic, we actually do try to get the drug within a therapeutic range, anywhere between 5 and 12 micrograms per mil. However, it's effective at much, much lower doses as an essential tremor agent, and you really are shooting to keep the levels lower than what you would as an antiepileptic. In fact, you really don't need to monitor the therapeutic levels of primidone when you're using it just for essential tremor treatment. And because of that, we generally start with really low doses of primidone, and we're usually pretty cautious about increasing the dose on this. So you generally want to start at just 25 milligrams, and you probably want to use it at bedtime. That's just to make the side effect profile a little bit more favorable. And you can usually increase up to 50 milligrams per day, and oftentimes you don't need to go any higher than that. If you look at package labeling, again, as an antiepileptic, primidone can go all the way up to 1,000 milligrams per day. But specifically when you're using it as a medication for the essential tremors, I'd be hesitant to go, the slide says above 200 milligrams per day. I would really be hesitant to go above 100. And most patients either respond or they don't respond to even those lower doses. So even the 25 milligrams or the 50 milligrams generally is sufficient for these patients. Again, there's certainly concerns with primidone, and unfortunately it's even more poorly tolerated than propranolol. So up to 72% of patients, and again, this is patients across the whole age spectrum, experience side effects with primidone. And again, these are some of the things that we're extremely concerned about in geriatric patients. So it can lead to confusion, ataxia, sedation, drowsiness, fatigue, dizziness. And again, this is generally thought of to be dose related. So if we're utilizing the lower doses and we're starting with the lower doses, oftentimes we can avoid these side effects. But also, like I mentioned, dosing these at night, if the patient does become tired or dizzy, you may be able to avoid some of those side effects as well. Primidone also can cause some hematologic side effects that are serious but relatively rare as well. Just in review of the essential tremor, so it may not impact the life to a degree that warrants medical treatment. So if the patient complains of it and you notice it, but it's not affecting their ability to eat, their ability to drink, their ability to dress themselves or perform some of their other activities of daily living, treatment may not be necessary right away. And if it is necessary, particularly if it's situationally related, you may be able to get away with just using an as-needed dose of propranolol, again starting with a very small dose. However, if the activities of daily living do become effective, then we should be considering either propranolol or primidone, starting both of those at very low doses, and titrating up as needed, again being very cognizant of the side effect profile. So the next movement disorder, and the one that we're going to focus on the most, is Parkinson's disease. So Parkinson's disease manifests as generally 4 cardinal motor symptoms, and we're probably familiar with all these. So the hallmark sign is the resting tremor that we describe as a pill-rolling tremor, and generally this is unilateral. It only happens to one side, which again is very different from the essential tremor. Now it's important to realize that patients can have Parkinson's disease and do have Parkinson's disease without any kind of tremor. But the other motor features or the motor symptoms include rigidity, so the patient's having very rigid movements that's oftentimes referred to as cogwheel rigidity, bradykinesia or slow movements, and then gait disturbance or postural instability. And a lot of these were focused on the last slide as well. Now there's also a number of other motor features, things like small handwriting, masked faces, softening voice, difficulty swallowing, and going through these freezing periods that also are important features of Parkinson's disease. And these are the things that we think about most, kind of the motor features. But as we see more and more of these Parkinson's disease patients, I think it becomes very clear that there's also a number of non-motor features that we really have to focus on. Things like mood disorders, sleep disturbances, autonomic dysfunction, so we can see these large fluctuations in blood pressure. So specifically orthostatic hypotension, we see some GI side effects, obviously sexual dysfunction, and then also oftentimes comes cognitive impairment as well. The mainstay of treatment for Parkinson's disease is and really always has been the use of levodopa. So the important thing with levodopa is that not only is it the mainstay of therapy, but if a patient responds favorably to levodopa, the symptomatic improvement to a trial of that basically confirms your diagnosis of Parkinson's disease. Now, if you are suspicious for Parkinson's disease and you give patients an adequate trial of levodopa, and I'll talk about what an adequate trial is, and they don't have any improvements in their symptoms, then maybe it's time to go back to the drawing board about what the initial diagnosis was. So levodopa is administered as a combination medication with carbidopa to prevent the peripheral breakdown of levodopa into dopamine. So as we can see here on this schematic down below here, there's basically levodopa that gets broken down into dopamine by dopa decarboxylase in the peripheral nervous system. Now this is important because dopamine does not have the ability to cross the blood-brain barrier. So you can generate all the dopamine you want out in the peripheral nervous system, but it's never going to be effective for Parkinson's disease because it cannot cross the blood-brain barrier and get to where it needs to work. Now this is also important because we need a sufficient amount of carbidopa to actually saturate these dopa decarboxylase receptors. Now it's thought that approximately 75 to 100 milligrams per day of carbidopa is needed to saturate those receptors. So when levodopa is given in a combination with carbidopa, you really need to focus on making sure that you have at least 75 milligrams of carbidopa as at least your initial dose to make sure that you're allowing enough levodopa to cross the blood-brain barrier and then get converted into dopamine in the central nervous system. So as you can see here, there's a number of formulations available of carbidopa-levodopa. There's immediate release tablets, there's extended release tablets, there's orally disintegrating tablets, there's a suspension, and then there's a really expensive extended release capsule version available as well. I've bolded and underlined the 25 per 100 milligrams because this provides 25 milligrams of carbidopa and 100 milligrams of levodopa per tablet. And generally our starting dose is using that and dosing that 3 times a day while the patient's awake. So this accomplishes 2 things. This accomplishes basically the lowest dose of levodopa that you can get, but also gives you a sufficient amount of carbidopa to saturate those dopa decarboxylase receptors in the periphery. Now, we get questions all the time from patients, from families, from pharmacy students, from medical students, asking, all these other medications we learned about. We learned that if we should probably use the extended release tablets if possible because it makes dosing easier for patients. And generally that is true. In the treatment of Parkinson's disease, this is probably not true. If you look at what's available in terms of extended release tablets, in order to get the appropriate amount of the carbidopa and a low dose of levodopa, you end up needing a decent amount of one or the other. And so it doesn't give you the same flexibility. And also the extended release really doesn't allow you much flexibility in terms of adjusting medications throughout specific points throughout the day. So I will talk in a couple slides about when maybe the extended release formula does come into play. The orally disintegrating tablets are extremely beneficial, particularly when patients' Parkinson's disease progresses to the point where they're having progressive dysphagia and they have problems swallowing their medications, particularly if they're having off periods. The orally disintegrating tablet can be something that can get them enough levodopa to kind of get through one of those off periods as well. So the adverse effects, as you would probably expect, are usually dopaminergic in nature, and these include things like nausea and vomiting, orthostatic hypotension, but oftentimes we can avoid these with starting with a low dose and titrating our way up as needed. Patients may also develop neurologic adverse effects, things like confusion, dizziness, peripheral neuropathies, hallucinations. These are all things that are very real, and oftentimes are the limiting factor for what allows us to adequately treat people with Parkinson's disease. Some of the dopamine-induced motor complications I'll talk about in the next slide. We consider carbidopa-levodopa to have a really, really narrow therapeutic window. So we have to get it to a certain level in the body to actually have it demonstrate its therapeutic effect. But if we get above a certain threshold, which we call the dyskinesia threshold, we start seeing these patients have these pretty debilitating dyskinesias. And this is basically what leads to some of these on and off periods and the wearing off effect that we see with this. And I'll have a couple slides here coming up that really show this in a more graphical way. So carbidopa-levodopa actually has a pretty short elimination half-life. It's actually only 90 minutes. But it's important to realize that especially early on in the disease, the duration of effect of the drug lasts well longer than the half-life of the drug. So as this picture shows down in the bottom, one single dose of carbidopa-levodopa can last well into 6 to 8 hours for patients early on in the disease process. And as I mentioned, this is the narrow therapeutic window that we have because we need to have enough levodopa on board that we can cross this therapeutic threshold, but we don't want so much on board that we exceed this dyskinesia threshold. So we really want to try to keep these levodopa levels kind of in this sweet spot. So as we'll see on the further slides, as the disease progresses, the therapeutic window and the time that we stay in the therapeutic window unfortunately gets smaller and smaller. And this is what's going to lead us to have to dose the medications more frequently, again, as the disease progresses. So when we get to moderate Parkinson's disease, we see that the drug does not last nearly as long as what it used to early on in the disease process. And so what the tendency is to want to do is to just increase the dose of the carbidopa-levodopa. Because the patient's taking the dose 3 times a day, which seems like that's frequent enough, and certainly for most classes of medications, 3 times a day is probably too much. But the thought is that if we increase the dose, we can extend the period of time that the levodopa maintains in that therapeutic range. However, that's usually not the case. Generally, the answer that we would lean more towards in these cases is that we actually increase the dosing frequency and keep the dose the same. Because if we just keep increasing the dose, what we end up seeing is this peak level of levodopa go above this dyskinesia threshold, and then that's when we see these patients having these dyskinesia problems. However, if we increase the frequency but keep the dose, we end up seeing these peaks not being quite as high, and then we see the peaks maintaining their level in this therapeutic range a little bit longer. And finally, in extremely advanced Parkinson's disease, patients tend to spend more periods of time outside that therapeutic window and more time in that off period than what they do in the on periods. And we have a very difficult balancing act of trying to figure out if we increase the dose, if we increase the frequency, if now is the time to add extended release medications, to really try to figure out what we need to do for these patients. But as you can see, especially as the disease progresses, we spend a significant amount of time in kind of the severely dyskinetic threshold, and then again a very significant amount of time in the subtherapeutic threshold, and sometimes patients are never able to get enough drug back on board to get back into that therapeutic window. So just a couple therapeutic pearls of dosing carbidopa and levodopa. Like I mentioned, I generally recommend that we start with the 25 milligrams of carbidopa, 100 milligrams of levodopa, and utilizing the immediate release version and using it 3 times per day. And again, this should help confirm the diagnosis. The 3 times a day should be done while awake, so the patient doesn't need to wake themselves in the middle of the night to give carbidopa. So really, if we do it every 5 to 6 hours, that's generally sufficient for getting spaced out enough. This probably as much, if not more than any other disease state that we treat, really requires pretty good attention from either the patient or the caregiver or both in terms of trying to figure out when these patients are having their on versus their off periods. So we oftentimes ask patients to keep a journal of specific times when the patient seems to be doing very well or very poorly. And then what we need to do is just try to fine-tune our medication regimen to address some of those times. We oftentimes see that we need to use the immediate release dosing up to 5 to 6 times per day, again, while patients are awake. And this ends up equating basically to every 2 to 3 hours. And while this is very burdensome, either for the patient or for the caregiver, this is oftentimes what it takes in order to keep those levels within the therapeutic window and also preventing them from having extended periods of off times. And one of the things that I mentioned a little bit earlier is the extended release formulation does really kind of have 2 specific advantages in my mind when we're talking about kind of 2 very specific situations. So if patients are having extended off periods during right when they wake up in the morning, using some extended release carbidopa levodopa overnight can be beneficial, because then you might be able to avoid that 8 to 12 hour period of them not having any levodopa. Also, if the patients are keeping good journals in terms of documenting their on and off times, and those time periods seem to be erratic and don't follow any specific pattern, then maybe that's the time that you need to just add an extended release version of the carbidopa levodopa just to get some more levodopa on board throughout the day. The next class of medications that we'll talk about are the dopamine agonists. So the old dopamine agonists are the ones that are the ergo derivatives, and we do not use those anymore because they were very poorly tolerated. So we're going to talk about the non-ergo derivatives, and these are the newer ones like pramipexole, ropinirole, and rotigotine. So these work very similarly to levodopa in that they stimulate dopamine receptors in the brain. Unfortunately, these have actually never been shown to have the same efficacy as levodopa. They've shown remotely close, but they've never shown to have the same efficacy as levodopa. They are longer acting than levodopa, and because of that, they potentially might have a less likely chance of having those wearing off effects like we do see with the carbidopa levodopa. So the ropinirole and pramipexole come in oral formulations, both immediate release and extended release tablets, and these are what we tend to gravitate towards more frequently. Ropinirole seems to be what we use most at the university. I think that's just because it's on formulary. But we generally start with the immediate release and titrate as necessary. It's important to realize that we generally do not titrate these more frequently than once a week. We really want to, again, start with a low dose and go slowly because we can avoid some of these dopaminergic side effects that I'll talk about in the next slide. I've seen very little use and utility of rotigotine. It is a transdermal formulation, so it can be extremely beneficial if patients are no longer able to swallow. Obviously, medications, both these are tablets. So if patients are no longer able to swallow, rotigotine does offer an advantage that it can be just given as a patch on the skin. So the adverse effect profile of the dopamine agonists is almost identical to carbidopa-levodopa. The acute adverse effects are dopaminergic in nature, and these generally consist of nausea, vomiting, orthostatic hypotension. And as I mentioned there, if we titrate the dose slowly and we start at a very low dose, these things can often be avoided. Some of the more severe side effects, again, these are not unique to the dopamine agonists, but very similar to carbidopa-levodopa, are things like hallucinations, cognitive impairment, sedation, dyskinesias. Unfortunately, the dopamine agonists are not devoid of dyskinesias. And one unique side effect of the dopamine agonists that we do not necessarily see with carbidopa-levodopa is this increased impulsivity. And this is extremely interesting. And I've actually seen this a couple times in patients in our clinic, where this impulsivity can manifest in a couple different ways. So I've seen patients have issues with pathologic gambling, people who both previously have had maybe some issues with gambling in the past, but also patients who have never gambled in their life, have all of a sudden taken up gambling and spent significant amounts of money. We see patients who undergo issues with hypersexuality, compulsive eating, and compulsive spending. I've previously met a patient who a group of their friends used to go out to lunch all the time, and all of a sudden he started buying lunch for a group of 15 of them week after week after week. And then finally one of the friends went to the wife and mentioned something, and he got his spending privileges taken away. So this is something that we do actually see, and something that you should be concerned about, specifically in patients who maybe have a history of any of these things, but also we've seen it in patients who have had no history of this. It's thought that maybe these hallucinations and impulsivity are maybe dose dependent, but that's not been conclusively shown to be the case. So again, starting with lower doses and utilizing lowest doses is still probably the best option. Much like the carbidopa-levodopa, we should not abruptly discontinue these. So we should really be thinking about tapering off of these at really weekly intervals. The transdermal can be done a little bit quicker if there is some sort of acute side effects that we worry about. But again, these are things that we absolutely would not want to stop without tapering off of them. So the place in therapy for dopamine agonists is a little bit unclear. I've already mentioned, and I think it should be clear, that carbidopa-levodopa is really the first-line treatment for patients. So the dopamine agonists, there's a potential where it can be used in kind of three different spots. So it can be used as an adjunct to carbidopa-levodopa to improve motor function and reduce some of these off periods because it does have a longer duration of action. So kind of in that situation where maybe you're thinking about utilizing an extended release version of carbidopa-levodopa, maybe you could consider a dopamine agonist. There is some thought that it can be used as an initial agent, especially in younger patients, so patients who develop Parkinson's disease in their 40s, 50s. There's still a thought that there might be a shelf life to levodopa, although this is still a little bit unclear. This might be used as kind of a levodopa sparing effect, where you can get away with the dopamine agonist for some period of time and then switch to carbidopa-levodopa. Again, this isn't clear that this is actually even beneficial or that it actually has any sparing effect on levodopa, but that's been thought of as a place in therapy. And then it's important that we realize that one of the other movement disorders that we'll talk about today is restless leg syndrome. The doses that we use of the dopamine agonists for Parkinson's disease are considerably higher than the doses that we use for restless leg treatment. But again, if you have a patient who's having both of these issues, so if they have Parkinson's disease and restless leg syndrome, a dopamine agonist might be a very appealing medication to consider. The next couple classes of medications that we'll talk about are becoming exceedingly less popular. The MAO-B inhibitors block the central metabolism of dopamine. So again, we're talking centrally here, and specifically this little box down here. Dopamine in the brain gets broken down into an inactive substance by MAO-B. So if you inhibit that enzyme, you can get more active dopamine in the brain. Like the dopamine agonist, there is still potential that this can be used as monotherapy in early diagnosis or as an adjunct to levodopa to kind of reduce the off period. So it has a very similar potential use profile as what our dopamine agonists do. So the two options we have for the MAO-B inhibitors are selegiline and rasagiline. Both of them are available as tablets. Now it's interesting that selegiline is available as a transdermal formulation. However, it's only FDA approved for major depressive disorder, and I personally have never seen a patient on selegiline patches strictly for Parkinson's disease. but in theory it probably could be considered, but again, it does not hold an FDA-approved labeling for that. But both of these have oral tablets and orally disintegrating tablets for the selegiline, which again can be beneficial if patients struggle with swallowing. And the doses here, much like the other medications we've talked about, should really be started at the lowest possible dose and titrated very slowly. Again, probably at the soonest after 2 to 4 weeks. Now, anyone who remembers pharmacology from way back may see MAO and think of the wine and cheese effect. So this is more pronounced with the MAO-A inhibitors, which prevents the metabolism of tyramine. So when you're thinking about foods that contain a lot of tyramine, so things like wine and cheeses, if patients are taking medications that inhibit MAO-A, it can lead to potentially fatal hypertensive emergencies. So the patients are unable to break up the tyramine and have these hypertensive emergencies. Now, selegiline and rasagiline are relatively selective for MAO-B. They're not 100% selective. So the risk is mostly theoretical, but these may not be something that you want to start in a patient whose diet only includes wine and cheeses. Again, although the risk is probably theoretical. So something that is considerably more serious is that we certainly want to avoid these medications in patients who are on any type of serotonergic drug. So these include SSRIs, TCAs, tramadol, and this is so serious that we need to discontinue any of the serotonergic drugs and wait for the full elimination of the drug. And if you recall, it takes 5 full half-lives for a drug to be completely eliminated from the system before we would consider starting one of the MAO-B inhibitors. Now, this is probably of particular importance because up to 70% of patients who have Parkinson's disease also suffer from depression. So there's a very good chance that your patient who could potentially benefit from one of these MAO-B inhibitors probably also needs one of these serotonergic drugs as well. The MAO-B inhibitors have not been shown to be as efficacious as levodopa, and they're largely considered not as effective as dopamine agonists, although trials have not confirmed that. Trials have largely shown that they're pretty similar to the dopamine agonists, but there's no debate that they're certainly not as effective as levodopa. And again, they cause very similar side effect profiles as the carbidopa-levodopa in that they cause nausea, headaches, confusion, hallucination. Rasagiline, interestingly, has been associated with impulsivity, but selegiline has not. So they say it's not a class effect. I'm not positive if you can actually say that. And then if you may have noticed that selegiline, you use a smaller dose when using with levodopa. And that's because dyskinesias do happen more frequently when you do combine the two medications. Now, the last true drug class that I'll talk about before talking about just a couple other miscellaneous drugs for Parkinson's disease are the COMT inhibitors. These work as well in the periphery, so going back to the peripheral nervous system, and these actually inhibit the other enzyme, not the dopa decarboxylase like we talked about earlier. They inhibit the COMT inhibitor, which breaks down levodopa into that other active metabolite. These have an interesting mechanism of action in that they were developed to be taken directly with carbidopa-levodopa. So if you combine it with the carbidopa that inhibits the dopa decarboxylase, and then you're also inhibiting this COMT inhibitor this COMT with the COMT inhibitor, then you essentially get even larger amounts of levodopa that are able to cross into the brain and become dopamine. It's been proposed to prolong the half-life of levodopa, so specifically thinking about further on into the disease process where patients are maybe having some of these wearing off effects and you're not quite ready to increase the dosing frequency. This is how these were proposed to be used. And there's 2 available agents and 1 combination agent. So the 2 available individual agents are entacapone and tolcapone. And as I mentioned, these have to be given with each dose of carbidopa-levodopa. So at the minimum, we're talking about probably 3 times per day dosing. And again, I've seen patients who have been taking the carbidopa-levodopa and one of the COMT inhibitors up to 5 times per day. And then there's a very expensive brand name available of a combination of carbidopa-levodopa and entacapone that's called Stalevo. I've never personally seen patients on this, again, because it's generally cost prohibitive. So the adverse effects, again, look very similar to all the medications that we utilize for Parkinson's disease. So we're talking about GI issues. One unique thing with the COMT inhibitors is that they have been shown to cause hepatic toxicity. So it is really important that if patients are on these, either if you've started them or you're inheriting them, that we're making sure that we're checking liver functions, probably at least annually, if not maybe twice a year. A unique side effect is that they actually can cause urine discoloration due to the accumulation of a metabolite. It's nothing concerning, but it can cause a discoloration of the urine. And much like everything else that we've talked about, we really don't want to abruptly discontinue these. So where do these come into therapy? And I think that's a good question. My answer is I don't know if there is great utility for these in the vast majority of patients. There's actually very little to no evidence that suggests that this is beneficial in either early or well-controlled Parkinson's disease. And on the other hand, they actually may be harmful because it may lead to both a shorter time to the onset of dyskinesias and increased frequency of dyskinesias. So certainly probably not a drug that you want to use early on in the disease process. They may be beneficial, and when I've seen patients who come to us on these, it's generally after seeing a neurologist, and they feel like they're not getting much more than 2 or 3 hours out of a carbidopa-levodopa dose, and they're trying to just prolong that efficacy time period just a little bit. However, one of the concerns with this is specifically if you're dosing it 3 or 4 times a day, patients are already taking 3 or 4 carbidopa-levodopa doses, and then you're adding another pill for each of those. As the disease progresses, we certainly get more concerned about dysphagia and patients' ability to swallow medications. So if we just keep adding more medications, that's absolutely something that we need to be cognizant of. So finally, there's just a couple medications that we'll talk about in terms of just miscellaneous things that can help for Parkinson's disease. So we have some centrally acting anticholinergics. You've probably seen benztropine, may have seen trihexylphenadil. I think the take-home message that I want you guys to have for this is that we should really never be using these in geriatric patients. They are centrally acting anticholinergic drugs that are going to lead to falls, that are going to lead to confusion, and basically going to make everything worse. They may have some utility, again, in younger patients, so the patients who you see who have very early onset Parkinson's disease, and they're actually able to tolerate some of these side effects. But really, these have very limited places in therapy, specifically for our geriatric patients. Now, amantadine was actually an antiviral that was found to have some potentially beneficial effects, specifically for people who had advanced Parkinson's disease, that actually for some reason helped decrease the both frequency and severity of dyskinesias. They think that the effects are thought to be due to some sort of NMDA receptor antagonism, but that's also very unclear. But you may or may not remember amantadine used for influenza probably 15 or so years ago. Now, just in review of Parkinson's disease, as I said, we would spend the most time on treatment options for that. It is characterized by kind of the cardinal 4 motor symptoms, and that's that resting pill rolling tremor, the cogwheel rigidity, bradykinesia, and postural instability. Again, levodopa remains kind of the mainstay of therapy and also can confirm a diagnosis if the patient responds well to it. The dopamine agonists also might provide a first-line alternative, specifically for younger patients if you're maybe concerned about preserving the levodopa effects. Again, that has never been shown to be conclusively true. And then other agents you can kind of use on a case-by-case basis, depending on how severe the patient's symptoms are and what specific symptoms you're looking to address. When we're considering adding any of these medications, we really want to be cognizant of the adverse effect profile. And if patients don't tolerate them, making sure that we're appropriately tapering them off of them and not just discontinuing them. Now, the last disease that we'll talk about is restless leg syndrome. And this is a very common complaint that we see quite frequently in our geriatrics clinic. So anyone who's seen a patient with restless leg syndrome knows how they describe these symptoms. They generally say they just have an urge that they need to move their legs. They have this sensation in them that feels like there's creepy crawlies in there, that it's burning, that it's tingling. And the only thing that they can get to make these symptoms better is if they get up and walk around. And generally, if they do that, it gets better. The symptoms usually begin at rest and are often worst at night when patients are laying in bed. And what these are is generally involuntary movements or sensations that, although they only last a few seconds, they can recur frequently and be relatively unpleasant for patients and have a big impact on quality of life, particularly their ability to fall asleep. With restless leg syndrome, it is extremely important that we rule out other secondary causes or concurrent diseases. So anemia, iron deficiency, renal disease, and peripheral neuropathy can either contribute to or mimic restless leg syndrome. So the dopamine agonists are generally first line, and we again talked about these when we talked about Parkinson's disease. So the ones that we really want to think about are ropinirole and pramipexole. And when we were talking about Parkinson's disease, I mentioned that we use considerably lower doses for restless leg syndrome than we do Parkinson's disease. So just make note of the maximum doses that we use for these, and that the maximum for ropinirole is 4 milligrams per day for restless leg syndrome, and pramipexole is 0.5 milligrams per day. One of the other things that I really want to point out with this is if you talk to patients who are taking any of these medications, really ask them when they take this, because the vast majority of people probably are not taking it correctly. So if you notice on the slide, it says that we should be having patients take these 1 to 3 hours before going to bed. The vast majority of patients that I've talked to take it literally as they're going into bed. So they pop it in their mouth, they drink a little glass of water, and they lay down. And then they still complain of symptoms. So we really want to make sure before we try increasing the dose or try starting something else that they're actually taking this appropriately. And I generally tell patients to try to take it 2 hours before bed. So depending on when they eat dinner, maybe just consider taking it with dinner. Now, it's important to realize that the dopamine agonists still have that same risk of impulsivity when used for restless leg syndrome as it is for Parkinson's disease. Although if you remember back to the Parkinson's disease slide, there is some thought that some of these things are dose-related. So if you can get by with lower doses, maybe you will decrease that risk. Carbidopa-levodopa is also a very viable option to use for restless leg syndrome. For some reason, patients and providers are a little bit hesitant to use carbidopa-levodopa just for restless leg syndrome. I want to put just for restless leg syndrome in quotations because I've heard that from a number of patients. But there's really no reason to be concerned about using carbidopa-levodopa aside from the side effect profile that we talk about, that again, if we utilize them at lower doses, we may be able to avoid. A couple things with carbidopa-levodopa specifically for restless leg syndrome. So it can also be beneficial on maybe not necessarily just a scheduled basis, but maybe as an as-needed basis. So if it's something that patients don't want to take every night, as-needed carbidopa-levodopa might be a reasonable option. And also we can try just starting with even 25 milligrams of carbidopa and 100 milligrams of levodopa, because we don't necessarily have to get that 75 milligrams of carbidopa to saturate those peripheral dopa decarboxylase inhibitors like we do for Parkinson's disease. So you may be able to get by with even a lower dose of the carbidopa-levodopa, and you could even maybe consider doing the 10-100 that was an option on those slides a few slides back. Now this is an interesting phenomenon that's just really picked up some attention over the past couple years, but both dopamine agonists and levodopa may be associated with an augmentation of the restless leg symptoms. So this is when patients are seeing kind of worsening symptoms despite continuing to go up in their doses of either carbidopa-levodopa or one of the dopamine agonists. So the risk of this augmentation increases with a couple different situations. So when patients are on larger doses of the medications, one specific study showed that if you have doses greater than 300 milligrams of levodopa, if patients have been on treatment for longer periods of time, and again, if they're anemic or have lower iron stores, this certainly puts patients at risk of having worsening symptoms of restless leg syndrome. One of the things that I always consider when patients are saying that they're having worsening symptoms despite needing more doses is, number one, that this augmentation could be actually what's going on, but also maybe trying backing off the dose and making sure that they're taking it appropriately. So again, a couple hours before bedtime as opposed to literally right before going into bed. A couple other options that we have for restless leg syndrome include gabapentin and pregabalin. These are particularly useful when patients also have a component of peripheral neuropathy involved as well. We can certainly utilize these as an add-on to a dopamine agonist or levodopa, or you can just use them as monotherapy. I always recommend when we're starting gabapentin to start at the lowest dose possible and making sure that patients tolerate that before we consider titrating it up. So starting with the 100 milligrams per day of gabapentin or 50 milligrams per day of pregabalin. And again, I think another important thing to realize here is the time that we're supposed to be having patients take this. So again, this is 1 to 3 hours before bedtime and not right as they get into bed. I listed benzodiazepines for completeness sake, but again, much like when we talked about the dystonic reactions, the benzodiazepines should really make you cringe. Clonazepam is really the only benzodiazepine with data for treating restless leg syndrome. But clonazepam, if you recall, actually has a long elimination half-life and should make us pretty squeamish to use in our elderly population. Now, just two kind of fun treatment modalities that we can talk about. This first one I actually learned from a patient. So this is a patient who's very involved in her care. I still see her. She always loves and comes with some sort of medication question for me. I think she thinks as a little bit of a game to see if she can stump me, which she has on numerous occasions. But she told me about placing a bar of lavender soap between the sheets, and that has helped relieve her symptoms of restless leg syndrome. So after she told me that, I went and did some research and actually found that there are some studies that support that this actually can help. Keep in mind the studies include about 5 patients. And so it's not robust clinical evidence, but I've had a couple patients and since that time I've asked a couple patients kind of jokingly, and they've told me that they've done this. So someone out there has talked about this, and some people say that it works. I've had a number of questions from patients and providers asking if it has to be lavender soap. A couple pharmacies actually make their own formulation of lavender soap, and it usually is that scent. The patient who told me about this said she used whatever was on sale. She was very cost conscientious, so she would use whatever she could find. At the time, I think she was using Irish Spring, so it didn't matter to her. But if you look at any kind of these trials that include 5 patients, they did use lavender soap. The nice thing about lavender soap between the sheets is that the side effect profile is extremely favorable. There's not much that can go wrong with that. Another option that used to be more of an option is quinine. So quinine actually, for some of our older practitioners, probably actually remember using this for restless leg syndrome because it has actually shown some efficacy for both nocturnal leg cramps and restless leg syndrome. However, as of 2010, the FDA recommended against using it, and now I think quinine is pretty difficult to obtain because it was associated with a lot of drug-drug interactions. And had some serious adverse effects, specifically in bigger doses. It can cause cardiac arrhythmias, tinnitus, dizziness, things like that. Again, interestingly, tonic water has a pretty small amount of quinine in it, but I have talked to patients who drink a little glass of quinine or of tonic water before going to bed and say that helps with their restless leg symptoms. So again, if using a small amount, as you see, 83 milligrams per liter, that's a pretty small amount of quinine in a large volume of liquid. Probably in a patient group that could drink some more water. That may be an option as well. So just a final review of restless leg syndrome. The first-line treatment options are actually very similar to Parkinson's disease. However, we always want to use smaller doses. And something that we should be conscientious of, aside from telling our patients to make sure that they're taking it a couple hours before bed, so 1 to 3 hours before bed, is that if we continue to increase these doses and the patient's symptoms seem to be getting worse, that actually could be the case. So we could be augmenting these symptoms and actually making things worse. Gabapentin actually can be an attractive option in patients with concurrent peripheral neuropathy. And again, starting at low doses, taking it at bedtime, we can oftentimes avoid some of those side effects that we see with gabapentin. And then some of these non-pharmacologic options like the bar soap in the bed offer a very safe option, again, without really any kind of efficacy data to support its use. But in a patient population that we're really focusing on doing no harm, that might be something that we can recommend. So just as an overall summary, movement disorders do present a difficult treatment conundrum as a number of the agents that we can use for these diseases are associated with a significant amount of side effects, both in young patients but specifically in geriatric patients as well. Acute onset dystonia should focus on a possible medication-induced side effect, specifically if it's something that's been recently started for a patient. Essential tremor can be managed with propranolol and primidone, but we do want to remain vigilant about the side effects with these. And specifically, we don't always need to treat the essential tremor. We can certainly see if it's impacting patients' quality of life. And then if quality of life does start becoming impacted, then we can consider one of those options. And remember that as needed propranolol can be a very beneficial treatment modality, specifically if it's when the tremor can be associated with specific stressors for patients. As I mentioned, levodopa therapy remains the mainstay of Parkinson's disease, which really requires attention to symptoms and personalization of medication regimens. So probably more than really any other disease state, Parkinson's disease, we really need to work with the patients, work with the caregivers, and really fine-tune that medication regimen to make sure that we're maximizing their on periods and minimizing their off periods. And then finally, restless leg syndrome treatment mimics Parkinson's disease, but at much lower doses. And with all of these things, I don't think I was able to mention enough that we really want to be cognizant of the side effects that do come with all of these treatment modalities. So thank you guys all for watching. I hope you're able to learn something about at least one of the movement disorders that we talked about. and maybe you're able to take something that can allow you to safely take care of your patients with some of these movement disorders. So I appreciate your time.